Yes, we are indeed.
Okay. Good morning, good afternoon, everyone. Thank you for joining us today. And thanks for the great cooperation with the World Hepatitis Alliance to jointly organize this webinar for the Eastern Mediterranean region. We are very happy that you were able to join the webinar today. We will talk about hepatitis B new guidelines that was released by WHO and how we can translate that into like the national frameworks of the hepatitis response in the countries in the Eastern Mediterranean region. So before we dive into the webinar, we have some housekeeping item that we are just going to display for you on the screen. So this webinar is being recorded, and we very much encourage you to use the Q&A feature in the chat if you want to ask any question. We very much encourage you to throw any questions to the panelists because we really want to make this session about interaction and about asking about the guidelines and how that could be translated into your countries. So without any further ado, let's start the webinar today. So the first session will be some opening remarks from both the Hepatitis Alliance and WHO. And I'm very happy to introduce the first speaker today, Rachel. She is the president of the World Hepatitis Alliance to give the opening remarks from her side. Over to you, Rachel.
Thank you very much, Ahmed, and good morning, everybody. And I'm delighted to be here with you this morning. This webinar is a really important point to reconvene as a region following not only the World Hepatitis Summit in Lisbon, which of course was in April, and I hope many of you were able to come, and World Hepatitis Day on July the 28th. The theme of World Hepatitis Day was to take action. And the release of the new global report from WHO at the summit highlighted that each year 1.3 million people die from hepatitis C, and this number is increasing. There is a real urgent need for action now. So World Hepatitis Day 2024 provided us with a platform for this message and made sure it was heard by those with the power to make real change happen. It amplified the voices of people living with hepatitis, demanding testing, treatment, vaccinations, and the end of stigma. It made it clear that there's no time to waste and that leaders and politicians, doctors and communities really must act now. So it's really great to come together today at the regional level following this important awareness day to discuss, as Ahmed's just said, the implementation of the new WHO guidelines on hepatitis B. These were first presented at the globally at the World Hepatitis Summit in 2024. The implementation of these guidelines will be an important step on the path to elimination, and we are delighted to be partnering with WHO today to further explore the implementation of these in the EMRO region, where 15.1 million people are living with hepatitis B, 2.3 million are diagnosed, and only 300,000 are on treatment. These figures are startling, but it's really important to remember that behind the numbers are people living with hepatitis and their families. And we have a responsibility to them to accelerate action and reach elimination so that no one else dies from an entirely preventable disease. I wish you a great session, and I look forward to seeing you in a little bit later in the meeting. Thank you, Ahmed.
Thank you, Rachel. And from WHO side, we are very happy to partner with you. As you said, the time left is very minimal. And I think everyone needs to come together to support countries in this pathway to be able to eliminate. From WHO side, we are also very happy to welcome our Acting Director of Communicable Disease, Dr. Nevin Wilson, to give also the opening remarks from the WHO side. Over to you, Nevin.
Thank you, Ahmed. Esteemed panelists, colleagues, participants, and importantly, the network of the World Health Alliance, whose members have made it their life's work to fight hepatitis. A very good morning, afternoon to all. The facts stare us in the face. Data tells us that about 15 million people in the Eastern Mediterranean region are living with chronic hepatitis B infection. Another estimated 12 million with chronic hepatitis C infection, leading to an estimated 97,000 deaths. Diagnosis and treatment coverage is low, especially for hepatitis B. Only 14% of people with hepatitis B are diagnosed and 2% receive treatment. While for hepatitis C, it's a little bit better. 48% are diagnosed and 35% receive treatment. The improvement in hepatitis C is mainly due to the determined leadership of the government of Egypt through their recent SEHA campaign, telling us that it is possible. Importantly, hepatitis B birth dose coverage is very low at 46%, far below the global target of 90%. We need and must accelerate the response for hepatitis B, and we have the tools for it. Guidelines that will be discussed today significantly simplify and broaden eligibility for treatment. They also address barriers to access testing and care. A pricing agreement for WHO pre-qualified hepatitis medication in low and middle-income countries has been coordinated by the Clinton Health Access Initiative, the Hepatitis Fund, and leading manufacturers. This mechanism makes hepatitis B and C medication available at affordable prices. National responses to the COVID-19 pandemic boosted molecular diagnostic capacity across the region. Let us leverage and harness this capacity in the fight against hepatitis. And lastly, ensuring equitable access to essential medicine, including hepatitis medication and testing, is a flagship initiative of our regional director. And the WHO regional office is working closely with member states and partners to make this a reality. A line in the What We Do tab of the Alliance's website captures well the key message to all of us. But we won't rest until hepatitis is eliminated. These guidelines are one of the steps in this fight. Thank you to partners and the Alliance in setting up this webinar, and we hope that we will have a very good interaction this morning. Over.
Thank you very much, Nevin, for these opening remarks and the very much key points that you highlighted, especially the opportunities that are available for our region and for the countries. And I think we will talk more about it in the coming presentation. Over to Dr. Mohammed Jamil to start moderating the next two sessions from WHO side. Jamil.
Thank you, Ahmed. Good morning, good afternoon, everyone. So it is my pleasure now to come in to moderate the next session, which will have two presentations. And this session will be then followed by another session where we will hear from two community members to give community perspectives from Egypt and Pakistan. So my name is Mohammed Jamil. I'm a technical officer for HIV, hepatitis, and STIs in WHO's regional office for the Eastern Mediterranean. And I'm based here in Cairo. Before I introduce the next speaker, I would encourage you to continue to introduce yourselves in the chat box and feel free to exchange ideas. We want it to be an interactive session. But for any questions directed to the speakers, I would encourage you to use the Q&A box. So I think our opening remarks beautifully set the scene for the webinar and highlight the need and urgency to scale up hepatitis response, particularly for hepatitis B in the region. But in order to further contextualize the epidemiology in the region, I would like to introduce our next speaker, who you have already heard during the start of the webinar. So it's my colleague here, Ahmed Sabri, who is also based in WHO EMRO in Cairo with me, and he's also a technical officer for HIV, hepatitis, STIs. So it's my pleasure to hand over to Ahmed now. You have 15 minutes for your presentation. Over to you, Ahmed.
Thank you, Jamil. Let me share my screen. So you see my screen, right?
Yes.
Very good. That's
Okay.
a slide mode.
It's slide mode, but can you, in the display setting, can you duplicate slideshow so we don't see the...
Okay, let me just do this. Okay, just one second. I will. So it's better now?
Yeah, you're on second slide.
Yes. So thank you again. So I will give a brief about the viral hepatitis in the Eastern Mediterranean region. I will talk about both B and C, but with a bit of focus on B, since this webinar is mainly to talk about the new guidelines for B. But just wanted to give you an overview of the epidemiology of viral hepatitis in the region. So our region is the Eastern Mediterranean region. So for those who don't know the structure of the region, we have 22 countries, as shown in the map. These countries are like very diverse in terms of the socioeconomic status. We have countries that's from like all the way from Morocco, all the way to Afghanistan, Pakistan, and Iran. It's a bit different from the MENA region. Sometimes people confuse it with the MENA region, but for the MENA region, they don't include Afghanistan, Pakistan, and Iran. And they have Algeria. For us, we include Afghanistan, Pakistan, Iran, and we don't have Algeria. So just wanted to make that distinction. So the figures that we will present will be talking about these 22 countries. And I'm sure you are all hearing the news about the emergencies that's going in the region. So at least 10 or 12 countries in the region are actually going through either a conflict or they're hosting like some refugees. So many countries in the region are going through like some emergency situations as well. And the region, as per the latest World Bank statistics, have like 600 million people. In terms of the burden of hepatitis B and C, as you can see from the graph on the left, if you see the one in orange, that's the prevalence of C. The Eastern Mediterranean region still has the highest prevalence of hepatitis C among all WHO regions. If you see, we are at 1.8% prevalence, far higher than all other WHO regions, which is translated to almost 12 million people living with hepatitis C in the region. And we will go in a minute to see where are all the cases in the region. If you look at the bars in the blue, this is the prevalence of hepatitis B. Our region is at like 2.1%. It's pretty much after Afro, the Western Pacific region, and the Southeast Asia region. We are at 2.1%. Which is actually translated to 15 million people living with hepatitis B. So we have 12 million C, we have 15 million B. If we go a bit into the how many new cases are happening and how many people are dying from both B and C, I pulled out the numbers from the latest data that were published. So for the incidence, we still have the highest incidence globally. We are estimating that in 2022, around 183,000 new cases happened for hepatitis C and around 86,000 cases for B. These two diseases still cause a lot of mortality, and a lot of people are dying from both hepatitis B and C. And actually, we are trying to establish systems across countries now to be able to measure the mortality in a better way. But the latest figure tells us that almost both B and C in the region are causing around like 100,000 hepatitis-related deaths. Of course, C is more, which comes like with 56,000 in 2022, and people dying from B in the same year were around like 41,000. So the message here is new cases are still happening in the region in very high numbers, and hepatitis is still causing a lot of mortality. And I think with all the efforts that we are doing, I think we need to do more to stop both the new infections from coming and also people from dying from hepatitis. To dive deep into the region, where are like the countries that most affected by both B and C? If you look at the graph on the left, so as you see, that's the distribution of the infections for B. We have like 5-6 countries that host most of the burden. Of course, Pakistan comes like top high in the list. So for B, Pakistan only has like 25% of the burden in the region. We have other countries like Iraq, like Iran, like Sudan, Somalia, Egypt, Yemen. These still contribute with a big portion as well, but most of the burden actually is in Pakistan. If we sum these countries together, it will make up to around like 85% of the burden in the region, and the rest of the countries just contribute to 15%. So this is actually a message that we really need to focus on these countries when we start talking about those guidelines and how to step up the effort in those countries, because if we manage to solve the problem in those countries, I think it will very much affect the whole region. If you look at the pie chart on the right, that's the distribution of the Hep C cases. And we have one country, as you see, that's contributing to 80%. 4 years ago, there were like 2 countries. It was like Egypt and Pakistan. But Egypt stepped up the fight against hepatitis C and managed to like take out most of the burden for hepatitis C, and we will talk about Egypt in a bit. But now Pakistan only has like 80% of the burden in the region, and the rest of the countries only contribute to like 20%. So there isn't much needed effort for Pakistan, and I know WHO, all the partners are trying to work for Pakistan, but I think we really need to consolidate our efforts more in Pakistan to be able to solve the problem there. I just wanted to show the progress along the 5 key interventions that WHO is recommending for countries to eliminate viral hepatitis. As you know, the Global Health Sector Strategy recommended these 5 key interventions. If we want to eliminate, we need to address these 5. And the yellow is the target that we should reach, and the green is actually the progress in the region. So in terms of the vaccination, at the 3 doses, we are quite doing a bit well, but we still need to move it better. We are at like 79%. We should be reaching 90% by 2030. For the burst dose, that's more problematic for our region. And I think this is one of the weakest points. We are almost 46%, almost half way through the target, which is like 90%. Blood and injection safety, we are still seeing a lot of problems that's related to those 2 areas. In some of the countries, we are achieving 92% injection safety. So this means 8% of the total injections that's being given in the region are still happening in unsafe way. But also most of these are happening in one country. And I think we really need to address it. Harm reduction is also one of the weakest points. That's for people who inject drugs. So our target is to reach 300 injections per person per year, syringes per person per year. We are only distributing an average of 27 syringes per person per year. Testing and treatment, hepatitis C, we are doing much better than B because of the efforts in Egypt. So we're almost diagnosing 50%, we are treating 35% of the burden. But for B is very much stagnant for the last 5-6 years. Only 14% know that they have hepatitis B, and only 2% are actually receiving the needed treatment. So I think there is a lot of efforts needed to address the 5 key interventions. So as you see, the prevention side, especially the burst dose, the harm reduction, blood and injection safety still need some efforts to be addressed. Hepatitis testing and treatment, many lessons to be learned from hepatitis C that happened in Egypt, and we really need to translate that to hepatitis B. And I think the new guidelines will talk about the testing, the treatment that countries should do to be able to move the agenda for hepatitis B. I just wanted to present quickly some programmatic progress in countries. So Many countries now have like either a focal point or a national strategy or established technical advisory group, but really the involvement of the civil society is still not as HIV. And not many countries have like the advocacy strategies that are needed to put hepatitis high in the agenda in those countries. So I think involvement of the civil society is very key. And I think we should really leverage those organizations working for the HIV towards the hepatitis. In terms of financing and pulling resources for hepatitis, not many countries also started allocating resources for hepatitis. So as you see, only like 7 countries in the region have like costed operational plans, and only like 3 or 4 countries were able to manage to mobilize resources to implement those plans. Sorry. In terms of the policies and the guidelines, I think we managed to produce many policies that's related to addressing viral hepatitis, whether it's for blood donations, for injection safety, the vaccinations, but we are still lacking the policies towards the key population. Not just that, but I will show later that some countries have these policies in place, but the implementation actually of these policies is the issue. So we have the setup, but we are not able to roll out the services. So that's the message from this slide. I know this webinar is about B, but maybe there are lessons also we need to look at from the work that happened in C. And I think the best example that should come is from Egypt. So Egypt had a long-standing problem for hepatitis C, as you all know. They had almost 5 million people with hepatitis C. It was a very long-standing public health problem in the country that was leading to many liver cancers and a lot of financial burden on the health system. And they needed a very large scale campaign to address this. So starting in 2016, they implemented the national campaign to test and treat everyone that has hepatitis C. And through the presidential initiative, they were able to screen almost 60 million people and give treatment to almost 4.1 million people. That helped actually Egypt to being validated to become the first country globally to achieve the path to elimination, the gold status of the path to elimination of hepatitis C. And that's the picture from the celebration in October last year, where DG, our regional director, the WR, met with the president of Egypt to hand the certificate. So briefly, we have many opportunities that happened in the region. We have success stories that we need to look at. As Nevin mentioned, COVID introduced a lot of capacities that we need to leverage. We have a good price deal that can secure like the medications for both B and C in a very cheap prices. We developed the new global health sector strategy and the regional action plan that's actually around the integration of services and strengthening the health system. And we really need to translate the actions on those 2 documents. But we still have challenges that we need to address. Financing for hepatitis is still limited. Still weak hepatitis programs in some countries. The cost of diagnostics is still high, and we need to leverage the deal that happened by WHA and WHO. The involvement of the civil society is an issue, as I said, and the data systems are, I think, is still not strong enough to capture all the relevant data that are needed to address or to track actually the progress for viral hepatitis. In conclusion, I think our region made progress in some areas, especially Hep B third dose, testing and treatment for C, but many areas need to be addressed, like burst dose, like injection safety, harm reduction, and testing and treatment for B. We have policies, as I said, but not fully translated, and countries need to leverage the resources and the deals that happened recently. So we need a very strong push for hepatitis B. That's very much lagging behind. And we're having the new guidelines that we'll be talking about today that we should really look into to transform the response for B in our region. Thank you very much. And over to you, Jamil.
Thank you. Thank you very much, Ahmed. If you don't mind muting yours. Yeah, great. Thank you very much for the comprehensive overview. And I think it was, you've set the scene really well for the following presentations. I would I see some questions are coming up in the Q&A box, which is great. So after the presentation, we will have time to address those questions. So please continue to post them. And I would like to now introduce our next speaker, who is Dr. Fumi Leschi, who is the hepatitis lead at the Global Hepatitis, HIV Hepatitis and STIs program in WHO headquarters based in Geneva. And she will give us an overview of a recent update to the WHO hepatitis B guidelines. And you heard in the beginning that there is like significant flexibility now in terms of who can be offered treatment. So we look forward to hearing the updates from you, Fumi. So please go ahead. Thank you.
Thank you very much, Jamil and Ahmed. And I would like to thank the World Hepatitis Alliance for this opportunity to share the new hepatitis B recommendations with you. It's been launched at the APASL conference and has been highlighted again at the World Hepatitis Summit. And we've had several global and regional disseminations. And I will share the link to these records. I just want to echo a bit of what Ahmed has talked about the mortality. Now, as a hepatologist, I have spent most of my life treating hepatitis and liver cancer and liver cirrhosis, especially in young people. So we are quite excited that this new hepatitis B guidelines will transform the global hepatitis response. And I wonder if I can share my screen at this point. And please let me know if you can see the screen.
Yeah, you do see the screen. If you can make it presentation mode. Yeah. Perfect.
Can you see presentation mode now?
Yeah, that's perfect.
Okay, so I would talk to the new WHO guidelines, and just to reiterate some of what Ahmed has said without taking a long time. We do know that viral hepatitis is a huge communicable disease with a mortality rate exceeding 1.3 million per year, making it one of the most impactful communicable disease of our age. And look at the numbers, 254 million people, 15 million of them residing in the EMRO region. And just to take a few moments to highlight some of the facts from the 2024 Hepatitis Global Report from WHO, which for our information included data from 187 countries, and that is huge. It shows clearly that the global coverage is low, and Ahmed has shown that it is far below the global targets. Countries have plans, countries have adopted some guidelines, but there is limited implementation, and the access has not yet shifted. At the bottom of this slide, I put some of how we can change. So getting on track will require treating an estimated 40 million people with hepatitis B and also treating hepatitis C by the end of 2026. I pulled this table again from the Global Hepatitis Report just to highlight what Ahmed has said. There's significant regional cultural variability in EMRO, which spans 2 continents, and data from Egypt, Morocco, Pakistan, Sudan, Yemen shows the importance of the high burden of hepatitis B infections in these countries. So let's get to hepatitis B recommendations. and what these recommendations mean. The last recommendation was made in 2015, and I want to highlight some things from that recommendation, which is nearly 10 years ago. The recommendation in 2015 focused on who to treat. And what I have highlighted in yellow, in red here, is we are looking to treat 10 years ago people who have advanced disease with an APRI score of greater than 2. An APRI score simply is a way to measure how healthy the liver is and to assess how scarred or how fibrotic the liver is. We also, at that time, recommended treatment for viral loads more than 20,000 international units. We recommended then drugs with a high barrier that has not changed, like TAF or entecavir, and in children, entecavir. And in 2020, we had added new guidelines for hepatitis B PMTCT, and that is for providing prophylaxis to women who had viral loads beyond 200,000 international units. So the question is, why do we need new guidelines at this time? For several reasons, as shown on this slide. There are still major gaps in testing and treatment uptake, some of which Ahmed has highlighted. And for many people, they consider the guidelines very, very complex. So as we have seen in HIV, as we've seen in hepatitis C, there's a need for what we call progressive simplification. Now, regional differences and demography is important, but note what we have seen from emerging evidence. The hepatitis B virus DNA integrates into the liver cell, and there's a significant oncogenicity and cancer rates in hepatitis B. And of course, we know there is ongoing new infections. And in terms of access challenge, we've seen many countries in low middle income areas, countries and regions with high prevalence do not have access to hepatitis B DNA and therefore are not able to make a diagnosis, not even to talk about treatment. So the process of making these guidelines was quite key and required collation of scientific and other evidence as shown on this slide. And I think to highlight that there was a guidelines development group with both global and regional experts and significant members of civil society. So this was really a huge discussion from all the necessary actors and stakeholders. We conducted 15 systematic reviews. There were modelings to look at proportions and eligibility. We had landscaping and access, and then we also had preference surveys, including from civil society and healthcare providers who provide this care. And the scope of these guidelines were huge, with 29 recommendations, 14 new, and spans the entire cascade of care. So I'm going to jump right into the first group of recommendations. And this is treatment recommended for all adults and adolescents more than 12 years who have hepatitis B. And for the first time ever, our recommendations for this group of people include pregnant women and girls and women of reproductive age, which means that the recommendations has implications not just for the adult population, but for adolescents and for women. So the first recommendation is evidence of significant fibrosis with an APRI score greater than 0.5 or the transient elastography more than 7. You can see already that we have moved from an APRI score of more than 2 and come down to the level of 0.5, which has implication for earlier diagnosis. The second is the hepatitis B DNA greater than 2,000 international units per liter and ALT above the normal limit. And also, number 3, the presence of co-infections. So people who have hepatitis B with a family history of liver cancer and cirrhosis are eligible for treatment, irrespective of their viral loads or liver enzymes. And in the absence of access to DNA assays, patients with persistently abnormal ALT levels can be treated. Now, the key message is the recommendations now focus on who to treat. These recommendations allow a common entry point for treatment. It provides simplification, makes it easy to implement it. And it also means that there will be many more pregnant and non-pregnant women and girls on treatment, not just for prophylaxis, but for their own health. And this recommendation complements expanded eligibility for antiviral therapy. You will see that these options will capture a higher proportion of people who will require treatment. And now this is about 50% versus 8 to 15% of the previous guidelines. Now, this is applicable to all settings, whether they have limited or no access to hepatitis B DNA, so it can be practiced in high upper income countries or lower middle income countries. And of course, the use of non-invasive tests. So there is a bit of science behind this, and I just want to summarize some of the important things here. And we see that the incidence rate of liver-related deaths are low under the viral load of 2,000. And in the graph in front of us, I look at the first blue and orange boxes here that show quite clearly reduced liver-related incident. And the increase in liver incidence in all these categories come with a viral load greater than 2,000. And in this slide, we see that the higher the viral load, the better or the more efficacious the treatment. And to put it simply, we use something called number needed to treat, which means at a viral load less than 2,000, we need to treat 137 people to prevent one cirrhosis, while at higher levels, you can see the lower numbers of people needed to be treated to prevent one of these morbidities. And this is what the guidelines look like in terms of algorithms, and I will come back to it. The second recommendation, the second group of recommendations are really about what are the first-line therapies. In our previous recommendation, we have strongly recommended tenofovir or entecavir, and these remain as the preferred regimens. But noting that in many countries where these regimens are unaffordable or not available, there is opportunity for alternative regimen using a combination therapy of tenofovir plus lamivudine or tenofovir and emtricitabine. This is particularly important in countries where they have a strong HIV program and these drugs are readily available in their program. On the right side of this screen, we can see some of the evidence base and the rationale. The systematic reviews show that there are similar outcomes for undetected hepatitis B, whether we use TAF or TDF. And also they show that dual therapy or TDF monotherapy has similar outcomes. So there's an opportunity here for expanding through dual access. The third group of recommendations I would like to focus on is preventing mother-to-child transmission. Our pre-existing strong recommendation is that in settings where DNA or E antigen is available, we prophylax women who have a high DNA or who have positive E antigen. The new recommendations recognizing that in high prevalence, high endemic areas, they did not have access to DNA or E antigen, and the E antigen testing has significant limitation especially in sub-Saharan Africa, where there's a huge burden of disease. In these settings, prophylaxis with TDF for all hepatitis B positive pregnant women may be considered. And of course, this is preferably in the second trimester of pregnancy until at least delivery. This has implications on the algorithm shown on the right, where we have two pink boxes that now demonstrate that DNA E antigen available, we have a strategy for that. And where it is not available, there is a strategy for that. And of course, the evidence base again is robust with systematic reviews showing the protective effect of antiviral therapy. But significant challenges remain because no studies have directly compared the clinical impact and feasibility of expanding prophylaxis to all positive women, but the modeling suggests that this may be a strong strategy, which is we call antiviral prophylaxis for all strategy. And the relative cost effectiveness of this strategy will depend on really the cost of commodity in countries. Other recommendations, which I will not go into detail, include the point of care DNA assays, which may be used as an alternative approach to laboratory-based DNA testing to assess viral load and to monitor treatment. And of course, we have the reflex DNA testing, which makes a lot of sense, is pragmatic, because this testing of DNA may be used as an additional strategy to promote linkage to care and treatment. And it can be achieved through laboratory-based reflex or even clinic-based reflex testing. We also have, some recommendations for hepatitis D testing, which I will really not expatiate on at this point, but we are recommending testing for hepatitis D for all hepatitis B positive patients, or depending on the region one may need to focus this in high endemic regions where there are facilities, and this will spur on the hepatitis D response. So in terms of service delivery, one of the key things in converting this hepatitis B epidemic, which has been highly specialized with care limited to tertiary center, to a public health response, sort of echoing the evolution of the response of HIV and hepatitis C. So strategies to promote linkage to care and testing and prevention are supported. Long-term adherence to antiviral therapy has been a challenge. We have learned a lot from HIV and even from Hep C that support is needed for adherence. So these new recommendations actually highlight some important approaches which will be required for a public health response. Now, integration of hepatitis care testing and treatment with all different services like HIV, like primary care, decentralization is important to increase efficiency and reach of these services. And I think my slides are coming to an end. One of the important things we need to look at is the research agenda and the implementation considerations. What do these guidelines mean for EMRO? What does it mean for the various regions? If we look at PMTCT, we know that there has to be increased coverage of hepatitis B burst dose vaccine, and that should be a priority. And Ahmed has highlighted how there's less than 45% coverage of hepatitis B burst dose in the EMRO region. So there's a lot of work to be done. We also need universal testing for surface antigen, hepatitis B, for HIV, and syphilis in the triple elimination. Of course, increasing healthcare capacity and providing simplified integrated care is important. In terms of the research agenda, there is a lot that need to be pragmatically tested, and implementation research is important for simplified service delivery, for monitoring, for surveillance, for liver cancer, and even for conducting the strategies required for reflex testing. And before I wrap up, I just want to highlight some more good news that really will even support the implementation of the guidelines, including the Gavi grant. There's a new grant application process for introducing the hepatitis B burst dose, and that provides a hope for many Gavi-supported countries. We know now that countries like Ethiopia and Sudan are planning to apply for this, and we encourage more countries to reach out for Gavi support. Also, countries that receive the Global Fund grants. Now we know that in the Global Fund grant GC7, there is a proviso for supporting hepatitis B in antenatal screening and testing. And to date, over $47 million have been allocated from over 40 countries to support purchasing commodities for ANC testing for hepatitis B. Of course, Dr. Wilson mentioned the WHA, the Hepatitis Fund agreement with generic suppliers for the landmark pricing. And there are more innovations coming. We know about the hepatitis C self-testing, and it has currently received WHO pre-qualification, but we're also now looking at hepatitis B self-testing. We have an oncoming guidance for strategic planning for hepatitis B and C testing, and we're encouraging countries to tailor their approach for testing and for treatment. And of course, there's ongoing data collection for hepatitis C in pregnancy. In terms of next steps, this is what we think will be important to scale up testing and case finding in all the regions, including EMRO, because early identification will lead to early treatment, will decrease the mortality rate, and really it's transformational for this hepatitis response. Updating national guidelines, widespread education, awareness-raising campaigns amongst the community as well as the healthcare workers, and promoting access to training, opportunities for cost reduction for hepatitis B medicines and diagnostics. We still need more reduction in diagnosis, and of course, supporting countries towards validation. I want to highlight this slide, which has the QR code, and we can all go to the various sites for the document, for the policy brief, for the launching presentation, which was to a global audience, and we will have more information at this point. So I want to thank very much the entire department, the HQ teams, the EMRO, and World Hepatitis Alliance. Thank you very much, and over to you, Jamil.
Thank you very much, Funmi, for the excellent presentation. So at this point, I will hand over to my co-moderator, Rachel, for moderating the next session, with a reminder to please add any questions in the Q&A box. We'll open up the floor for discussion after the next session. Over to you, Rachel.
Thank you, Jamal, and thank you, Funmi and Ahmed, for your fantastic presentations, really comprehensive. And I think Funmi particularly, you know, we have so many tools, you know, there's an excitement about it. Yeah. But if I think back to Ahmed's presentation, there's also so much to do in the EMRO region, so much, you know, and what we know is that civil society, community organisations need to be at the centre of this, particularly when it comes to raising awareness, testing, linkage to care. I hear Ahmed is saying that, you know, there's lesser community organisations within the EMRO region, but we are really fortunate today to have a couple of organisations to provide their perspective to us this afternoon or this morning, wherever you are. So it gives me great pleasure to hand over to Dr. Gamal. So Dr. Gamal is a WHA board member, the regional EMRO board member, and he's going to provide a brief perspective, community perspective, I guess, on viral hepatitis in the EMRO region from the community. Over to you, Dr. Gamal.
Yes, thank you very much. And as Dr. Ahmed Sabri mentioned, and Dr. Jamil, that EMRO region has millions of patients with both hepatitis C and hepatitis B. And there are many organizations in several countries, especially in Pakistan and Egypt, and few organizations in Afghanistan and Yemen and other countries. They are all working for hepatitis elimination. But the situation varies according to the presence or absence of a comprehensive national program. For example, in Pakistan, there are initiatives from the government, and there are many NGOs in Pakistan working for awareness and testing and helping the people to reach or to have access to treatment. They work separately from the government, but the governmental plans in Pakistan are promising, but at the same time, the work done by the NGOs and members of the World Hepatitis Alliance in Pakistan needs encouragement and needs a lot of expansion, because the size of the problem in Pakistan is very big. There are about 10 millions in Pakistan having hepatitis C and about 2 millions having hepatitis B. A similar situation, but different, is Yemen. Yemen is a country with a high prevalence of hepatitis B and C, and the political situation there is not encouraging a national, well-organized national plan. But our members there from the World Hepatitis Alliance are working on the ground, and they asked repeatedly for support, and we need to support them both from WHO and from World Hepatitis Alliance. There are other countries who needs a lot of support, but I think, and maybe in World Hepatitis Alliance we are arranging a meeting for the members in order to put an action plan, how to work together and how to support the individual activities for awareness, testing, and treatment on the ground. And there is one important issue that I asked the WHO to help, which is the agreement between the Clinton Foundation and the Hepatitis Fund, I think, to support the generics in many countries, especially in the countries with low-income countries. This is not on the ground yet in many countries, and still the price for hepatitis B treatment in many countries of low income is still this offer is not there, and also for hepatitis C, and many organizations who are members of World Hepatitis Alliance are asking me as a representative for the area to implement this. So I call for support for this. So I think we are on the track, but we need to put a realistic action plan and meet more frequently with all the people active on the ground. And I want to thank the organizers of this event, because it's a step forward on that direction. Thank you.
Thank you, Gamal. That's a great overview. Importantly, and I think we saw this in Ahmed's presentation as well, you mentioned Pakistan, which has the highest prevalence in the EMRO region. So actually, I'm delighted to introduce you to Professor Yazar, who is going to be delivering a presentation on his community perspective on Pakistan. And I believe you have a presentation, Yazar?
Yes, I have.
I'm delighted to hand over to you then.
Thank you. So my screen is visible, my slides are.
If you'd just like to put them into presentation mode, that's it. Brilliant.
Yes.
Thank you.
So my presentation is visible?
Yes. Yes, it is.
Thank you. Thank you for the invitation. My name is Yasir Wahid. I am professor at National University of Science and Technology in Pakistan, and also the CEO of Bridging Health Foundation. So I will discuss about hepatitis B awareness and screening. So as one slide about the global burden, as many people has already discussed that hepatitis B is a big problem. So globally, 254 million people are living with hepatitis B virus. And the major issue for with hepatitis B virus is that the most of the people who are living with hepatitis B virus, they are undiagnosed. So approximately 13% of the people who are living with hepatitis B virus are diagnosed, and 3% of them has received the antiviral therapy. So this data is basically from the WHO Global Hepatitis Report. So in case of the Pakistan is a big country with a population of 251 million people. So according to Polaris data, Pakistan has 3.8 million cases of hepatitis B virus and 9.86 million cases of hepatitis C virus. Only 22% of hepatitis B virus and 18% of hepatitis C virus cases are diagnosed. So we are far behind the WHO targets of achieving hepatitis B and C screening in the country. So in next few slides, I will discuss about the small initiative we are doing in our community about the hepatitis awareness and screening. Because I'm working as a professor in the university, so I assigned hepatitis screening and awareness work to my different undergraduate and postgraduate students. So one of my students has completed his thesis work on hepatitis B and C screening in the refugees camp. So in Pakistan, we have a big population of refugees in Pakistan. We conducted hepatitis awareness and screening in the refugees displaced from Pakistan, India, disputed Kashmir, and living in refugees camp in Pakistan since 1989. We provided hepatitis awareness to the 11 different refugees camp, and we screened 550 refugees. So by screening, we found that the prevalence of HBV antibodies are 4.36% and HCV positive rate was 6.54% in the refugees population of the Pakistan. We also did a small study for the screening of hepatitis B, C, and HIV in the people who inject drugs in Pakistan. We provided awareness to them, and also we screened them for B, C, and HIV. The hepatitis B prevalence rates were found to be 23%. We are basically conducting screening and awareness camp in different high-risk population group. So we conducted a camp in which we provided hepatitis B and C awareness and screening in the people who are living in the slums of Rawalpindi city of Pakistan. So in this camp, we screened 153 pregnant women and 3.2% were HBV positive. We also conducted a study for screening of hepatitis B and C in thalassemia population in Pakistan, in the capital twin cities of the Pakistan, and the prevalence of HBV was found about 3%. So from Pakistan, we publish a big data on from our perspective, it is a population of 160,000 people who are screened for hepatitis B, C, and HIV. And basically this population was a blood donor population. And the prevalence of hepatitis B was found to be 2.35% in the blood donors community, and C prevalence was 3.26%. Similarly, on this World Hepatitis Day, one of our friends from the NACE, he has organized a hepatitis hackathon. And in this hepatitis hackathon, we invited university students from different universities, and I provided them, I was a guest speaker on the situation of hepatitis B and C in Pakistan, and we were expecting from them to have come with new ideas how to deal with the situation of hepatitis in Pakistan. So it was a very successful camp, and at the end of the camp, the president, the CEO of World Hepatitis Alliance, Kerry James, also joined. So on this World Hepatitis Day, Kerry James was in Pakistan, and we took this opportunity and organized hepatitis World Hepatitis Day at our university in the medical school. So Kerry James and I conducted a session on the situation of hepatitis B and C, and to increase the awareness in the Pakistani population and the disease burden of hepatitis in our university. So we are doing small initiative to provide hepatitis awareness and screening in different population group. Like this camp we have conducted in the homeless population. Then we try to reach out the religious schools and provide them awareness about hepatitis B and C. Then we are conducting camps in different schools in the village area, in the cities. And we are also trying to increase hepatitis by having session on print, like on electronic media, and by publishing articles on hepatitis B and C in the electronic media. So the conclusion of my presentation that the burden of hepatitis B and C are very high in the Pakistani population and in many other countries. And many countries have developed hepatitis control program. But the major issue is the lack of the financial resources to achieve these targets. So there is a need to invest money in the fight against hepatitis and to provide hepatitis-free screening and treatment to the people who are living in the country like Pakistan, and which have a very high burden of hepatitis B and C. Thank you.
Thank you, Yasir. I mean, I think that was a really comprehensive overview of Pakistan. And I think just, you know, as you said, the World Hepatitis Alliance, Carrie was there with you on World Hepatitis Day, as was WHO, because there was an announcement from your government, which was, you know, support to eliminate.
Yes.
I think, as you've already said, that absolutely there is support, and we're all conscious of the fact that every country needs action plans and support.
Yes.
There's still financing, and it's about how do we move that forward. But really positive to hear the governmental support on World Hepatitis Day. So I'm actually going to bring Jamil back in now, and we are just going to moderate this final session where we've got an opportunity for you to ask some questions. So you can we've got questions in the Q&A section. But if you'd like to raise your hand, we can open up your mic so that you can ask in person if anybody has a question that they'd like to ask in person. Thank you to both Gamal and Yasir. And perhaps if all the people who presented would like to pop their cameras back on, then we can open up a Q&A and answer some of these questions that are in the Q&A. Hand over to you, Jamal, just for a minute to see if there's anything that's popped that has stood out to you in the Q&A to begin with.
Sure. Thanks, Rachel. And thanks also to Gamal and Yasir for excellent remarks and interventions. So I have pulled a couple of questions from the Q&A just to kick us off. And I can pose those questions. But as Rachel said, if you are comfortable framing your questions verbally, we would be happy to open the floor for you to do that. So please raise your hands. I'll put both the questions forward. So the first one is, it's an interesting question going to Ahmed, asking for the criteria for the screening of blood donation, which is like 100% of blood donation screened. And the question is for blood and injection safety, how do we calculate the 100% screen donation? So I think if you can just sort of clarify the criteria and how do we measure that. And then I'll leave the panelists with the second question, which is, I think, really important, which was around working with the refugee communities. So the question was that how can we build partnerships to support refugees to have information available to them about viral hepatitis? And what are the opportunities for refugees and refugee-led organizations to mitigate hepatitis B and also hepatitis C in the refugee camps or for those populations? And we can even, I think, broadly speak to how can the communities be supported? I saw Yasir alluded to the work in refugee camps, so perhaps he might want to comment. So start with them, and then I invite other panelists to respond to the other question. Over to you, Ahmed.
Thank you, Jamil. I think it's a great question, actually. So these are indicators that we use. That's part of what we call 10 core indicators to monitor the progress towards elimination of viral hepatitis. One of them is to track the blood safety. One of them is to track injection safety. What do we mean by blood safety? We are mainly looking at the proportion of blood donated that's screened for bloodborne diseases in quality assured manner. So we usually take all the total number of blood units that's donated, and we want to see if all of them were screened for infectious disease like bloodborne disease or not, including, of course, hepatitis B and C. Usually, the blood centers have this data, and we try to pull this from each country. And at the regional level, we try to establish the regional statistics for this. So it's actually very much straightforward in terms of calculation at the country level, and we pull it to the regional level. Unfortunately, for the last 3-4 years, we don't have the figure on the regional level. As you saw in my presentation, I put it non-available because I think our blood safety here in EMRO is still working on the new figure for EMRO. As for injection safety, we are also looking at the proportion of healthcare facilities that's is practicing the safe injection. Safe injection, we mean they are using therapeutic injections that are given with single use or standard disposals or auto disable syringes. These are also measured through specific surveys at the facility level, or either measured sometimes as part of the demographic health surveys. So countries are measuring that in a way or another, and we pull this information also at the regional level to establish the regional figure. Usually modulars also help us with those to just do the pooling and the weighting at each country to establish the regional figure. I will share also in the chat the consolidated strategic information guidelines that was developed last year and published this year. It has all the core indicators that we are tracking, and it has also how to measure and how to track each indicator, all the relevant information for each indicator. I think it's pretty concise, and it will definitely help everyone to read also this document. I will leave the question about the refugees to the civil society, but maybe I will comment at the end. I hope this clarifies the question. I will put the document in the chat as well.
So for refugee scan, basically, Pakistan had the high burden of hepatitis B and C. And our aim was to reach out the refugee scan. In Pakistan has one of the highest burden of refugees. So I assigned a project to one of my postgraduate students to reach out the refugee scan. So it is not easy to reach to this population, as the camps are not in the cities. They are isolated or into the far-flung or away areas. So we took proper approval from the government to reach out these communities, and then we reach the refugee population. We convinced them that this is a beneficial step for you, and we provided them hepatitis screening, and we also have our friends who are medical specialists, and we conducted free clinics from them. So we provided them hepatitis B and C screening and free diagnosis also for other diseases. To the refugees camp. So honestly speaking, this population are really ignored and isolated. So I will also stress out that it is important to reach out the people, the high-risk population or the population who are isolated and no one is paying attention to them. So I also want to conclude that we should also go to look towards the other communities who are the high-risk population groups, and to see what is the situation of hepatitis in them. Thank you.
Thank you. I think Fumi wanted to jump in there as well. Thank you, Yassi. Fumi, did you want to say something? I'm not sure whether it was about refugees or about blood safety.
I thank you. I think this is a very exciting discussion, and I just want to address some of the comments in response to the question, because I must tell you that blood donor screening and injection safety are not done yet. So in terms of blood donor screening, yes, I hear that there's 100% blood screening policy in many countries, but did you know that many countries use rapid test kits to screen for hepatitis B and C? And sometimes in certain countries, the quality of the kits is insufficient, that there is significant breakthrough infections. And I think there is a role for civil society here. For example, in one of my states we have in Nigeria, the quality of the kits may be part of why there's an ongoing epidemic of hepatitis B, or more importantly, C. So we cannot treat our way out of the hepatitis C response. We need to address prevention as well. Now, one of the weak areas, even in blood banking services, is in the private sector. In some countries that have private blood bank services, although the coverage may be near 100, we need to look at the quality of that coverage and the implications for breakthrough infection. And linkage to care from blood banks. We say that sometimes the blood bank is the richest source of free testing for hepatitis B and C, completely free. And we have not harnessed the power of blood banking services, the testing provided in blood banking services, and the linkage to care that is required for those patients. It'll be good to have an idea of what civil society can do, working collaboratively to make sure that that avenue is plugged. In terms of injection safety and measurements, thank you very much, Ahmed, for highlighting this. But a deeper question may be, what about the injection practices in the community? After all, we know that the evidence from Pakistan has shown very clearly that sometimes the weaknesses in injection safety is not only in health facilities, but is in the community. And I know that barbing salons, dental chairs, all of those are sources of infection in the community. And I think civil society has a huge role to play in addressing these. It's something that we can talk about and I think is important. In terms of the refugee, again, thank you for that question. There are so many approaches in that question, and I will just give an example of Cox's Bazar. It's been in the news recently, where there's a lot of hepatitis C in the community, where there's no burst dose. So the government, the partners, and WHO were trying to support that community, but you know that communities cannot exist outside the country. We need to look at the policies in place for that country. So we came across this when we came to burst dose. How do we begin to give burst dose for all the babies born in the refugee camp when the hosting country does not have a policy for burst dose? So these are issues we need to address. Again, for example, Cox's Bazar, we've heard about the very high rates of hepatitis C. We're looking into this. There are studies going on, there are partners in there, and we're working collaboratively to see what can be done. But in hepatitis B and C, we need to remember that, yes, the refugee population are very important, but perhaps the country policy also has to be strengthened for the population of the country as well as for the population in the refugee camps. So I think there's a lot of back and forth, a lot of discussion. We don't have all the answers. And I think it's something we can creatively discuss. Thank you very much. And Jamil, back to you.
Thank you, Fumi. I have questions back on that, but I can see Ahmed's hand is up first. So Ahmed, over to you.
Yeah, it's gonna be quick. Thank you so much, Fumi, for highlighting the piece about the community practice. I think it's a behavioral change issue as well. I mean, at this side of the world, and I am coming from Egypt and I visit many countries in the region, I think there is a lot of unneeded injections happening. I mean, people actually tend to believe that injection is better than pills. They go to the doctor and they ask actually to write injections. So this is like unneeded injection that's happening already that should be cut down. So it's should be looked at it also from like a behavioral change issue, and as well as a policy issue. And I think one of the things that Egypt did with the implementation of the 100 million Sahha, the presidential initiative, they tried actually to address some of the injection safety and the community practice in terms of the barber shops, etc. They implemented some initiatives that were really helpful, and I think it will be really good to actually look at those in details for other countries as well. So just wanted to comment on that piece. Sorry for coming in. Over to you, Rachel.
No, it's absolutely fine. I mean, I think in many countries across the world, there are standards, that have to be adhered to, practices. But I think Yazir is going to come in on that because I think things are beginning to change in Pakistan. Am I right?
I want to add a couple of things with reference to the discussion that like 3 years back, we have conducted a study like in Pakistan, like we thought that barbers are also a source from where people are getting hepatitis B and C infection. And the potash alum stone, we observed that it was a common stone, which was at that time rubbed on the facial shaving cuts. So we have seen that, you can see that this is a picture of potash alum stone. And it is, you can see thick blood spots on that spot. So we published many years back in virology journal that this plus potash alum stone might be a factor in the transmission of hepatitis B, C in Pakistan. And it has like it was very commonly used by the barbers community. And I want to add another thing about the kits, which were the part of discussion, that the different kits which were being used in different countries. Like in Pakistan, there are maybe like 100 kits which are being used for the screening of hepatitis B and C. So we conducted an evaluation study and evaluated the performance of different hepatitis C kits which are available in Pakistani population for screening of hepatitis C virus. And we recommended a couple of kits which showed very good specificity and sensitivity for the screening of hepatitis B, hepatitis C particularly. And we, in our published study, we endorsed that these kits can be used for the screening of hepatitis C in bigger population groups. Thank you.
Thank you. Yeah. I mean, I guess there are so many different possible routes of transmission, I think, when we're talking about, historically, particularly in Pakistan. And that will translate to other countries, I'm sure, across the EMRO region as well. Jamal, is there any other questions that you've picked up there that you'd like to put forward?
I do have a couple of questions that I picked from the chat box, but I do see that one of the attendees has raised their hand. Adil Malik. I just wanted to see if Adil would like to articulate the question.
Thank you very much.
Go ahead.
I really enjoyed listening to the presentation from different distinguished speakers. I have a question to Lisa. In case of co-infection of HIV and Hep C or B, since we are seeing a lot of cases like that, is the criteria for starting treatment still applicable, the new one? And which of which you start first? And are you considering level of CD4 to say, I will start with this first or that one first, or viral load, whatever? Back to you.
I think that was for me. Do you want to come in?
All right, thank you very much. I thank Adele for the question, and it's a very, very valid question. And I must say that in many countries where HIV has a high prevalence and care, many of the HIV co-infected persons with B are automatically started on a tenofovir containing regimen. It's actually an old recommendation, and it's even before HIV went to treat all. There is a recommendation that every HIV person who has hepatitis B should be on tenofovir containing regimen. And we have learned so much about the population of HIV on tenofovir because we're seeing lower cancer rates, hepatitis B-related cancers in HIV patients, simply because they have started hepatitis B treatment even before, even without meeting the hepatitis B treatment criteria. So to simplify it, the issue of hepatitis B HIV, I think it's been addressed at source because of this recommendation. The bigger challenge will be in HIV HCV because there's also a recommendation in HIV that testing for HCV should be offered. So there's a lot of testing going on. Sometimes the challenge is the DAAs for treating the HIV patient. So we're really happy that an organization like Global Fund is supporting hepatitis C treatment in key populations, in HIV populations, and I encourage all countries to take advantage of that. And I think that a lot of co-infections have been addressed this way. I think I'll stop right there because I know that Prof also may have their experiences on HIV, HBV, and HIV, HCV co-infections. And over. Thank you.
Thanks for me. Maybe just to add on HIV, Hep B co-infection, that's probably the simplest of all. And with the current first-line regimen for HIV, the combination already has 2 drugs active on hepatitis B. So if the patient is on first line for HIV, you don't need to add additional treatment for Hep B. But if they are on a different regimen, then you need to make sure that you have like two drugs active on hepatitis B. So I think we can also follow up one-on-one for any like kind of specifics, but that's just general principles. Maybe I see Nadia Badran had put some comments and has her hand raised as well. I will let her take the floor, but I'll add a question, I think, which is a really important one in the Q&A box as well, around PMTCT. And I think that the question comes from Pakistan for Pakistan, but I think it's has relevance broadly, and it is to do with the issue of scaling up bird dose vaccine for Hep B in Pakistan to address mother-to-child transmission. And I think more importantly as well to raise awareness about preventing hepatitis B transmission for mother-to-child. So I'll frame that question, and then if we can let Nadia come in with her question as well.
Yeah, you want me to ask a question, Dr. Neil?
Please go ahead. You had your hand up. So.
Yes, thank you. It is a very interesting webinar today. But also, like what I wanted to say, that the situation of hepatitis in Lebanon and the program around hepatitis, it's very like it is not existing. So we are doing vaccine for hepatitis B for key population in Lebanon, but it is on very limited scale because the number of vaccine that we receive from the government, it's very limited. As for testing, for rapid tests we are using, but we are purchasing as NGOs rapid tests for HIV and for hepatitis B and C, I mean, and we are doing it in the center and in the mobile unit through outreach and peer education mobile and through the mobile unit. The problem is all of this, it's an effort from the civil society only. There is no input from our government. So my question is the like the regional office of WHO EMRO will be in touch with our government around this subject, and when? Because we are ready also to support in that. And for harm reduction, because also you were talking, Mr. Ahmad, about harm reduction, and it's important. We are delivering harm reduction kits for people who are using needles. So we are distributing and sometimes exchanging needles. So we are running also this program. But as I said, there is no much governance for this program in Lebanon. It's only some from time to time initiatives from the civil society, but this it is not cannot have impact on the epidemic. And another thing, because you were mentioning refugees in Lebanon, yes, we do have Syrian refugees in Lebanon and other migrant people who are hepatitis B and hepatitis C positive, and they cannot have their treatment. So the treatment also, it's a big issue in Lebanon. Treatment for hepatitis C, they do not exist. It exists only to purchase from a drugstore or from a pharmacy, but it's not supported by the government as it was like before COVID. We were purchasing it from Egypt, and it was available for a very for $40, I remember. So so we do have people who are on OAT treatment. They are HCV positive. They are not getting their treatment. We do have refugees. If they are not pregnant women, they do not have access to any of hepatitis B or C treatment. And for the vaccine, it is on very little scale. We are doing it for key population. I'm not talking for general people, general population. Yes, thank you. Sorry.
Thank you very much, Nadia. Well noted, and we'll make sure to follow up with you afterwards as well to discuss the possibility and opportunities. I'm cautious of the time, so I just wanted to see with Rachel if you wanted to frame another question or say any sort of closing remarks before we go to the closing. So over to you.
No, I'm going to leave the final closing remarks to you, but I just want to say thank you so much to everybody. It's been a really important webinar, a great opportunity. I almost wish that we had more time. I think there is so much to discuss and so much to do. But I guess my one comment would be is that, you know, we need governmental action plans, you know, civil society, absolutely, but none of us can do anything unless we have the foundation of a governmental action plan, which is backed by finance. You know, it feels a little bit like we're a house and we don't have the roof on because the roof is our governmental action plan. But we have all the tools and yeah, so much opportunity. And I do hope that we have an opportunity to come together and meet again and have further discussions on this. I think that we've only just discussed the surface. So I'm going to hand back to Jamil. I just want to say thank you so much. It's been a fantastic webinar, and over to you, Jamil, to close.
Thank you. Thank you very much, Rachel. I just had a request from Ahmed for a 30 seconds intervention. So go ahead, Ahmed.
No, just quickly. I mean, we have been discussing the guidelines this webinar, and I just wanted to extend the thanks just to the people who actually worked on to formulate the guidelines, because there has been like a big group of experts to formulate these guidelines, and I think we have also some of them on our webinar. So just wanted to extend our thanks and appreciation to them. Yes, just wanted to say that. Over to you, Jamil.
Thank you very much. Unfortunately, we've run out of time and we want to be respectful of your time. So I would encourage the panelists, if there are any remaining questions, to please answer them in the chat box, or we can also sort of draft some responses afterwards. I did see that really interesting questions were coming in, but unfortunately we have to cut short because of the time. So just in terms of closing, I won't take very long, but I just wanted to, first of all, thank the World Hepatitis Alliance for this collaboration, and we look forward to continuing this in the future. I wanted to thank all the presenters for their excellent presentations and also for being punctual with the time. So that's really appreciated. And most of all, the participants who have joined, the communities who are present. So thanks for your participation and active engagement. We really appreciate it. Just in terms of, I think, next steps, we have the guidelines, as you have seen now and learned, that they are very permissive and flexible, but they really need to be implemented and adapted at the country level, in the countries on the ground, to be able to, scale up national response and achieve impact. So I think that's where we need to be, and we need to work collaboratively together for that to happen. And we need to work really closely with the communities, keeping communities at the center. It's very obvious that there's a lot that communities can do, including advocating with their governments. So they raise their commitment to addressing hepatitis B and C in their countries. I think it's really important to build capacities at the national level for both diagnostics, linkage, and treatment scale up, leveraging opportunities that are currently available, including both for affordable pricing, but also, funding using existing streams. I didn't want to have some discussion on that, but unfortunately we didn't have time. And then lastly, as a technical partner, WHO and partners, we are available, and we remain, always available to support countries and programs in scaling up their responses. So feel free to follow up with us afterwards, and we'll be more than happy to discuss and see how we can support you. So with that, thanks again, everyone, for a really great webinar, and we'll look forward to continuing engaging in this space. Thank you.
Thank you all. Take care.
Thank you.
Thank you.
Thank you.